Welcome to Lesson 1 of our Dental Clinic Masterclass, History Taking. Okay, so there's this huge misconception we need to clear up right away. When you first step into the clinic, you might totally assume that pulling off flawless restorations, doing complex root canals, or perfectly placing implants are the most important skills you need to have. Well, guess what? They're really not. I know that sounds a bit crazy, but the absolute most important skill in dentistry is actually taking a proper history. Why? Because if you don't know what's actually wrong with the patient in the first place, no amount of technical skill with a drill is going to fix their problem. It really boils down to this. A good history gives you the diagnosis before you even pick up a mirror or a probe. If you can become a master at taking a patient's history, you literally become a master diagnostician. The physical, hands-on procedures, they just follow the roadmap that your conversation has already drawn for you. Let's put this into practice. Picture this. A patient walks into your clinic for the very first time. She sits down in the chair, looks up at you, smiles nervously, and says, "Doctor, my tooth is paining." This is, without a doubt, the most common starting point you are ever going to face. So what's your first move? A lot of fresh dentists get super eager to just dive in and solve the puzzle, so they immediately lean forward and ask, which tooth? Now that's not a terrible question by any means, but it's just not enough. It's actually a bit of a rookie mistake because it instantly narrows your focus to a single tooth and completely skips the most crucial part of building rapport with a real human being. Instead, you want to start by making them feel comfortable. Smile, introduce yourself, say something simple like, "Hello, I'm Dr. Fatima. Tell me what has been bothering you." This shows the sheer power of an open-ended question. It lets the patient explain what's going on in their own words. And here is the golden rule for you. Do not interrupt. If you just let them speak freely, patients will very often hand you the exact diagnosis on a silver platter. All right, let's make this official. Step 1, the chief complaint, or CC. The chief complaint is simply the primary reason the patient came to see you today. And here's the trick. You have to write it in their own words whenever you possibly can. So you would write down something like pain in lower left back tooth for 3 days. You absolutely do not write down irreversible pulpitis. Why? Because irreversible pulpitis is your clinical diagnosis, not their complaint. Keep all your fancy clinical jargon out of it and document their experience exactly as they describe it to you. Moving right along to step 2, the history of present illness, or HPI. Once you have their chief complaint jotted down, it is time to put on your detective hat. To make sure we never, ever miss a clue, senior dentists use a very specific framework. It's called Socrates. This is a classic diagnostic mnemonic used all across medicine and dentistry to systematically investigate what's going on. Think of it as your ultimate deductive toolkit for solving the medical mystery of a toothache. Let's break these letters down, shall we? S is for sight. You ask, can you point to the tooth? But be careful, because pain can be tricky and spread, meaning patients sometimes point to the wrong tooth. You always want to examine the neighbors. O is for onset. When did it start? A pain that popped up yesterday has a completely different cause than a pain that's been lingering for 6 months. C is for character. How does it feel? Is it dull, stabbing, burning, or maybe like an electric shock? And R is for radiation. Does the pain travel anywhere, like up to the ear, the temple, or even the opposite jaw? Pulpal pain loves to radiate, whereas periodontal pain is usually stuck in one localized spot. Let's pause for a super helpful clinical pearl regarding the character of that pain. If your patient tells you it's a throbbing pain, that is a huge hint that the pulp is inflamed. On the flip side, if they get a sharp pain when they drink something cold, but it fades away quickly once the cold is gone, that often points to reversible pulpitis. Just by actively listening to their adjectives, you're already narrowing down the diagnosis in your head. Okay, next is the A in Socrates, associated symptoms. You've got to ask about the surrounding environment. Is there any swelling? Do they have a fever? Are they getting a weird bad taste in their mouth? Are they struggling to open their mouth wide or finding it hard to swallow? These symptoms are massive clues that help you judge just how severe an infection might be. T stands for timing. Is the pain constant or does it sort of come and go? And here is the kicker. You must ask, does it wake you up at night? Listen, night pain is a massive diagnostic red flag. It is a classic feature of irreversible pulpitis. If they tell you the pain is waking them up out of a dead sleep, you are almost certainly dealing with a highly inflamed dying nerve. Next up is E for exacerbating and relieving factors. Basically, what makes it worse? Is it hot coffee, biting down, or maybe lying flat in bed? And what actually makes it better? Is it painkillers or just nothing at all? You really want to pay attention if they mention cold water. If a patient says, "Doctor, holding cold water in my mouth is the only thing that gives me relief," that is a textbook sign of symptomatic, irreversible pulpitis. The cold is literally shrinking the tissues and temporarily reducing the pressure inside that super inflamed pulp chamber. It's just brilliant biology revealing itself right there in conversation.
And finally, the last S in Socrates is severity. Ask them, on a scale where 0 is no pain and 10 is the absolute worst pain you've ever felt in your life, where are you at right now? Grabbing this number isn't just about showing empathy, it gives you a solid baseline so you can track how much better they're doing after you treat them.
Now for the absolute lifesaver, medical history.
So we're zooming out from the tooth and looking at the entire body. You can never, and I mean never, assume someone is perfectly healthy just because they walked into your clinic looking totally fine. You have to actively run through the big systemic conditions. Ask them straight up, do you have diabetes, high blood pressure, heart disease, asthma, or thyroid issues? What about your liver or kidneys? Ever had a stroke or major surgery? And if appropriate, are you pregnant? These are definitely not just annoying boxes to check on an intake form. These specific conditions dictate whether a basic extraction goes smoothly or spirals into a massive medical emergency right there in your chair. And listen, you cannot just stop at yes. If a patient says, yes, I have diabetes, a great dentist immediately fires off a cascade of vital follow-up questions. Is it type 1 or type 2? What exact medications are you taking for it? What was your last blood sugar reading, and is it generally controlled? Have you eaten anything today? Think about it. If you pump local anesthesia with adrenaline into a diabetic who hasn't eaten all day, they could crash straight into hypoglycemia. Your follow-up questions are what keep them safe. We're almost to the finish line. The final checks, drugs, and allergies secrets. When it comes to their current medications, a lot of patients honestly have no idea what the medical names of their pills are, or even why they take them. So instead of vaguely asking, are you taking any medications, which usually just gets you a blank stare, try this. Ask, can you show me your tablets or maybe a photo of them on your phone? Visual proof is everything here. You have to watch like a hawk for blood thinners, which can cause major bleeding, or steroids, and meds for blood pressure. All of those will completely alter your treatment plan. Finally, the allergy check. Do not just ask a generic, any allergies? People almost always just reflexively say no. You have to ask specific behavioral questions. Have you ever had a weird reaction to a medicine? Did you ever get puffy or swell up after an injection? Ever had trouble breathing after taking a pill? Any issues with latex gloves or certain foods? Now, a true, genuine allergy to modern local anesthetics is incredibly rare, but you still absolutely have to investigate it thoroughly to avoid something terrifying like anaphylaxis. So, as we wrap up our very first explainer together, I want to leave you with this thought to chew on. History taking isn't just annoying paperwork. It is literally high-level clinical detective work. Next time you sit in a dental chair yourself, or the next time you have a patient sit in yours, will you notice all the brilliant, calculated detective work happening before the drill even turns on? Mastering this conversation is the true mark of a great clinician. I really hope this gives you a boost of practical confidence, and I absolutely cannot wait to dive into our next lesson with you.